Okay, so today we're just going to go through very quickly how we're going to intubate during COVID-19 era. Normally, most people will intubate with direct laryngoscopy. In other words, you'll be very close to the patient's mouth. You'll have to see the vocal cord, and then you'll have to intubate. But because of the very high risk of droplet spreading and aerosolization, we are encouraging every intubation is done by video laryngoscopy. Two most common device is either CMAC device or Glidoscope. So today we're going to demonstrate very quickly the use of both devices. As you can see, CMAC has several types of blade, a D blade, a size 3 and a size 4. The most important step for you to do before you start intubating using CMAC is to put a stylet inside your ET tube, and you have to mold the shape of the ET tube according to the shape of your CMAC blade. So if you're using a D blade CMAC, it has to be this shape so that when you're inserting through the vocal cord, it follows the blade. So clearly, if you are using a size 3 blade, this is not the right shape. You'll need it to make it this shape. And if you're using a size 4, it's very similar to a size 3 CMAC blade. So for this demonstration, I'm going to use a D blade, as you can see. So the technique that you're going to use is that you're going to use a screen, a big screen instead of a small screen if you have, and you're going to stand quite far away from the patient. Make sure you put on your PPE. You enter the mouth, and the view that you want to get is you want the tongue inside the view. And when you see the tongue, you start sliding your blade slowly inside until you sit inside the vallecula, and you lift up the epiglottis and you'll see the vocal cord. At any point, if you see secretion, you don't advance, because any secretion on the camera will make the view blurry. So you will have to do a gentle direct suction with the anchor. So once you get a view, now this is the most important technique. When you put the ET tube through the mouth, make sure the ET tube cuff doesn't get injured by the teeth, because if you get a cuff rupture, it's a disaster, right? Once you're inside, you follow the curvature of the laryngoscope. As you can see, there is hardly any resistance, and you shouldn't feel any resistance. The curvature should just bring you straight through the vocal cord. And once you're in the vocal cord, you pull out the stylet a little bit, so that will enable you to push your ET tube in. You will now notice two black lines on the ET tube. You want to put your vocal cord in between the two black lines. So if you look at in the camera, I'm pushing my ET tube, and I will stop around about there, which means the second black line is outside the vocal cord. Once that's done, only then I'll remove my laryngoscope blade. I will get my helper to inflate the ET tube cuff. I'll remove the stylet and immediately attach to a ventilator circuit, which I have already pre-prepared before I start the RSI, which has got the closed suction circuit and also a HME viral filter attached, together with an anti-tidal CO2 to the ventilator circuit. So once we attach to the ventilator circuit, in theory, you don't need to listen to the chest anymore. You don't need to use a CO2 detector, and you don't also need to do any chest x-ray, because you've done your intubation confirmation through direct vision. By avoiding all this other checking mechanism, you're reducing your risk of getting a COVID-19 infection. If you are predicting a narrowed airway or a difficult airway, you may decide to intubate using a bougie instead of a stylet inside the ET tube. If you want to do a bougie, make sure you get a bougie with enough memory. What I mean is that when you bend the bougie will remain relatively bent. Okay, that's what you need, a moldable bougie. What you don't want to use is a bougie that has no memory. In other words, you try to bend it, and it will straighten up like a spring. You don't want this kind of bougie because you'll almost certainly fail. So when you get this bougie, you mold it and it develops some sort of a curve, and you do the same technique. You slowly insert your laryngoscope blade, a two-handed technique. Once you inside the vallecula, you very gently insert your bougie using the curve through the vocal cord. Once you inside the vocal cord, you get your assistants to help you put the ET tube. Again, the same way, you need to be careful not to injure the ET tube cuff on the teeth. Once you're in, you advance your ET tube. Most of the time at this stage, your ET tube will be stuck there, okay? Just before you go through the vocal folds there, through the arytenoid. Okay, a way to get around this is to turn, don't force it. Turn your ET tube anti-clockwise 90 degrees. Once the ET tube bevel is upwards, now you can push and it will just go straight into, and you do the same technique, you stop between the two lines. Okay? Just to show you, this is the bevel, if you've not seen it before. If you want to get it through the vocal cord easily, you turn it anti-clockwise, and then hopefully it should just go up very easily. Okay, so if you are intubating using a glidoscope, as you can see, the shape is much more curved and much more angled than the CMAC. So the only way to intubate this with a higher success rate is using a stylet. So you have to do this yourself. You insert a stylet, and once the stylet is in, you need to create an L shape. Okay, make sure that the stylet doesn't go out too much in the end. Okay, you need to make an L shape. Once you have that, you use the same technique as the CMAC. You enter carefully. That's not a great view. You want a view with the tongue. Okay, once you have the tongue, you keep on looking at the tongue and you slide your blade in slowly until you see the epiglottis, and then you're inside the vallecula. If you notice, I have left myself a little bit of space at the mouth so that I can put my ET tube in. This is another important step. If you look at the mouth, I want to avoid the teeth, as I said before, not to rupture the cuff, but I'm entering the mouth with the ET tube at 90 degrees angle to the face. So once I'm in, gently I slowly turn. As I start seeing my ET tube there, I will turn it forward, and then I will move my ET tube in. If you notice, so if you look at this movement now, I'm turning in, and as I'm looking at the screen, then I'm in. So at some point, because it's at 90 degrees, I can't push it forward. I will need to pull my stylet out, and at the same time, I'm pushing the ET tube in. And with the same technique, I will stop at the vocal cord between the first and the second black line. Once I see that, I remove my glidoscope out, inflate the cuff, and remove the stylet and attach straight onto the ventilator. If you happen to use the standard ET tube, you will not get two lines, you will only get one line. So if your ET tube have one line, you just need to stop around about the black line, your vocal cord. Okay, don't make it disappear too far, and definitely don't make it too superficial. At some point, you either be successful in intubating the patient, or you think you have failed. If you felt you have failed the intubation, then you should proceed very quickly to try to oxygenate the patient. We will not do BVM. If we can avoid, we'll go straight for an LMA, ideally LMA size 4 for an adult. You would open the package and just go straight into the patient's mouth. You'll inflate it, okay, and you'll ventilate the patient. Okay, when you ventilate the patient, you need to do two things. you need to sense with your left hand that there is not so much leak at the mouth. And the second one, the more important one, you need to see that the chest is rising. By this stage, it'd probably be too risky to just wait for the saturation to come up, because most of the time the saturation is very low, then always going to be a lag in saturation. Maybe it'll go up after 1 minute. If you're confident the chest is rising, then you can continue to bag the patient. If you cannot sense that the chest is rising, or if there is too much leak at the mouth, I suspect you'd have to proceed very quickly for surgical cricothyroidotomy as a rescue airway device. Just another reminder, make sure you prepare the correct size of a laryngeal mask before you start your RSI process. Size 4 is for most adult in general, and 5 for bigger adult, and 3 for smaller. Just a quick reminder, most of these patients, they'll be very hypoxic, which means the saturation will be very low. So many of them, doesn't matter how much you pre-oxygenate them, you will have to start the intubation process or the RSI process while them desaturating. So it's very difficult to use saturation as a guide, because your saturation will drop almost immediately when you give your RSI drug. So another simple measure to use to decide when to abandon attempt of intubation is by using the heart rate. If you sense the heart rate is starting to go down, in other words, you start off with the heart rate of 120, slowly going down to 110 to 100, then at that stage, I think you should declare you have failed to intubate this patient and move on to laryngeal mask or surgical airway, because you don't want the patient to reach bradycardia of 50 or 60, because that's a pre-arrest situation.